Welcome to our Satellite Symposium of Digestive Cancers Europe. My name is Stefan Gijssels and I'm the CEO of the organization. The topic of today is leading change for improved patient outcomes. And I will give a short introduction on the value of patient organizations, explaining what it is that we do. Digestive Cancers Europe represents the patient community in Europe. We have 30 members across the region. That, as you can see on the slide, is bigger than the European Union, representing patients with cancer of the esophagus, stomach, pancreas, liver, colon, rectum, and rare digestive cancers. Every year, 900,000 patients get diagnosed with one of these diseases, and 600,000 of them die. We try to represent both the patients and their family and caregivers to make sure that their lives are improved as best as possible. That's our goal, to reduce the overall incidence and mortality of digestive cancers, but at the same time making sure that the quality of life for patients and carers is improved. Our aspiration is to save 250,000 lives by 2028. And as this may look like a lot of people, but if every country and every hospital applied best practices with existing technology, that result would already be achieved today. Just to show you the potential upside of applying best practices. What do we do as patient organizations? Actually, we work at two different levels. We work at the individual level, helping patients to manage their disease throughout the patient journey. So once they've been diagnosed and are taken to the hospital for treatment, they have a lot of questions on a psychological nature, relational, educational, social, professional, financial, bureaucratic, practical, you name it. We try to help them. Some of our association have 24/7 help desk facilities where patients can come with any question they have. We are organizing peer-to-peer situations so that patients also can understand what other patients have gone through and how they have solved the issues that they are confronted with. It is clear that patients who are educated and informed about their disease, patients who are not isolated, patients who are helped to navigate all the different aspects of the disease also have better outcomes. So we help the individual patient in that sense, but that as a totality, we also help their families and society at large. The second thing that we do is to aggregate all the experiences, the insights, the information we receive from individual patients to come with a more comprehensive view of what can be done to improve the system, whether it's the policy environment or the medical practice. We have a lot of insights and views on what can be done to make the patient pathway a lot more effective and efficient. We also work on prevention, we work on access and affordability. And of course, we also participate in research projects because we still need a lot to develop to get patients the best possible treatment. So these two levels, individual level and the collective level, together demonstrate the value we bring to all the different stakeholders we work with, including hospitals, governments, of course, patients themselves, the research community, and also industry. Today, we will zoom in on 4 specific topics related to that. I will start by discussing the importance and the value of having the correct data to make systems changes and to lead change. Then my colleague Vassiliki Fotaki will talk about driving the research agenda to meet patients' needs. Jola Gore-Booth will talk about colorectal cancer screening with the question, are we succeeding? And Zorana Maravic will end the symposium with a presentation on the survey that was done in the last few years on understanding the unmet needs of patients. So I want to thank you in advance for the interest that you have in this topic. After the presentation, if you're interested, feel free to contact us, and we are very open to collaboration and participation in new projects. Feel free to contact us, and many thanks in advance. Good afternoon. My name is Stefan Gijssels, and I represent Digestive Cancers Europe. In the next few minutes, I will talk about the importance of data collection as a measure to make our health system more rational. And it may be a little bit provocative, but bear with me. because I think it is extremely important. Today, our health system basically navigates in the dark. There are some spots where the street light is shining, and that is a place where you can see what is happening. But in the majority of our healthcare system, there is no light. That means there is no information. We don't see anything, despite the fact that it is there in that reality outside. If you break this down in a quadrant between health economics and health outcomes from the individual to the collective level, you can see that within the light of the street light, we have clarity on the price of drugs or the hospital budget or the budget for medtech and diagnostics or the overall drugs budget. We have light on the effectiveness of technology X as compared to technology Y. What we do not have, for instance, is hospital outcomes data, or even outcomes data by country. Nobody can tell with precision how many colorectal cancer patients survived last year, or gastric cancer patients survived last year in this or that country, let alone that you would know it by week or by month. Nobody has any idea on the treatment outcomes data in a real world environment. Let alone that you would know it with precision on stage of the disease, age of the patient, or more specifics about their profile. We have no ideas on the value of comprehensive cancer networks, despite the fact that we see that they generate better outcomes than the general hospitals. We have no value estimation on shared decision-making models, situations where patients and doctors collectively decide on what is the best option for the patient. We have no estimation of the value of informal care, despite the fact that it is very important in bringing the patient back to the situation as before. We have no idea on how much money is spent on individual drugs in their totality in a market. We have no idea on the savings that can be generated from screening, despite the fact that the countries where the screening is done and the health economic evaluation has been made, it is clear that it saves money. So what are they doing and why is nobody else measuring it? There is no evaluation on the value of patient organization, despite the fact that tens of thousands of volunteers participate in making sure that donations are generated and patients are supported through help desk facilities or other services. We have no clear idea on the economic value of survival. So despite the fact that today many patients live who would have been dead 20 years ago, and maybe back at work if they're in the work-related age, we don't measure that. So we know one part of the equation, how much money goes into the budget. We have no idea what is actually done with it afterwards or what it leads to. That's a major gap. Unless you have all that information together, it's impossible to make health policy decisions, and that's what we're after. Our system at the moment is fragmentary and irrational because it lacks the data to make decisions. Some observations. Some countries have data. For instance, the Netherlands, 48% of colorectal cancer patients are diagnosed in stage 1 as compared to 13% on average in the EU. That is the result of fantastic good screening program for colorectal cancer they have in the Netherlands. Data like that of best practice make it possible to see what can be done to reach the same topic. In other countries, people are dying in a massive scale because it's, you have 90% overall survival in stage 1 as compared to 8 to 10% in stage 4. Why doesn't everybody know these data and look what can be done to make it happen? Some of the largest hospitals or specialized hospitals have 85% overall survival in colorectal cancer patients as compared to 55% on average. And that's not only across Europe, because I think there's a lot of discussion about the difference between East and West and North and South, but within a member state, this is the difference, 30 percentage point difference. The same we see in mortality 1 month after colorectal cancer surgery, 10 to 20 times higher in non-specialized hospitals within a member state. These are data from the Netherlands, Belgium, Germany, and France, and Sweden, countries where the data are available. even if not very updated, even if not very transparent, because it's sometimes not possible to identify which hospital is behind the good and the bad figures. Nobody wants to share these data, or nobody is interested to share these data, but that's what you need. Without these data, it's impossible to have a health policy that looks at effectiveness and efficiency of means. The total annual healthcare cost of cancer in the European Union is 100 billion euro. That's a huge amount of money. In totality, it's even 200 billion euro if you look at all the non-medical costs of it. The indirect costs on premature mortality, on work-related productivity, and on informal care. Possibly, according to the OECD, 20% of that amount, or 20 billion euro, is wasted money. It's invested in places where it doesn't lead to any better outcome than before. So we do not have the correct and complete data to make rational health policy decisions, is one of the conclusions we can draw from this. Second, massive amounts of patients receive suboptimal treatment. 3, there is significant underinvestment in the most effective measures. 4, massive amounts of money go into scientific research, like biology, technology, but rarely any into systems effectiveness research. So despite the fact that we have fantastic innovation in Europe, it's not applied everywhere. It's only limited use in limited number of centers. What can we do to make sure that innovations get traction in every hospital in Europe? And then the key questions on health outcomes remain unaddressed. How many people survive? And if they survive, because of which treatment? And what else have they done? How is the hospital care organized, or the total patient pathway organized to reach these outcomes? It's, considering the amount of money invested, a shame that these questions remain unaddressed. Imagine a company that invests in research, manufacturing, distribution, and marketing with no data on sales, nor data on competitors, and no data on the best salesperson, no data on return on investment. They just pour money in this huge machine, and they keep pouring money and investing and doing whatever burns money. And they manufacture, but they have no clue what happens afterwards with it. And I think that is a little bit the reality that we are living in our health system. We invest in pharmaceuticals, we invest in prevention, we invest in hospitals, we invest in workforce, all that with taxpayers' money, but we have no idea in a systematic way on patient outcomes. We have no data on patient preferences. We have no data on where the best practices are generated in a systematic way. We have no data on the return on investment. So our expectations is that in order to have a rational healthcare system, we need the following data. Transparent and real-time data on every disease and by every hospital, on age, stage, gender, ethnicity of the individual patient, with a treatment pathway of diagnosis, treatment, support received, complications, follow-up received, etc. 5-year survival data, patient-determined quality of life data, recurrence, etc. On top of that, we need a comparative analysis of aggregated outcomes data by hospital and by treatment, taking into account, of course, the complexity of the case and the number of patients treated. This will allow for identification of best outcomes and best practices. And then, as a third level, we need health economic analysis at the patient level and the societal level. What is the treatment cost? What is the informal care cost? And what is the premature mortality and morbidity cost of the patient? Because if you only look at the treatment cost as one part of the equation, and you do not calculate what is the actual benefit of it from a societal or even patient perspective, how can you qualify whether it's sustainable or not? How can you determine whether it's expensive or not? You have to evaluate it versus the outcome and not versus the existing technology. So not one cancer registry in Europe is able to provide all these data. We have strong figures on input data, who receive how much money, but we have no data on what this money actually achieves. And what is the value of innovation if nobody tracks whether it is used and whether it achieves the expected results? This is not difficult, what I'm asking. It is relatively easy to organize with limited funding, but nobody does it. The way forward is that every stakeholder who receives taxpayers' money, and that includes hospitals, doctors, and pharma companies, should be able to provide detailed data on the outcomes they achieve with the money received. We have to spend 1% of cancer healthcare costs, or €1 billion, in data generation. It may potentially save €20 billion of wasted money. Think of that. Might be an interesting concept. Third, data are owned by the patient, and I think we should set up a data donation program where patients collectively share their data and put it together in one single database or system. And we, as patient organization, are able, as a neutral and objective third party, to manage these data. This European patient-owned data repository will make it possible for everybody at any time to collect the data that are needed to make healthcare decisions. If you're interested, I'm open to discuss this. We are open to look at ways that can be set up to have solutions to this. I know in my presentation I gave a number of figures. We obviously have the sources to and the calculations to substantiate those. Please reach out to us if you have more demand for information on this topic. My preferred slogan is, show me what you measure and I will tell you what you care about. So unless it is possible to measure everything that I've just described in terms of patient outcomes, both in terms of survival and quality of life, I think it is very difficult to make the claim that you care about patients. If you care, show that you measure data and follow up to make sure that the system is better. Thank you for your attention, and I hope we will be in touch soon. Thank you.
Welcome everyone to our Satellite Symposium, Leading Change for Improved Patient Outcomes. I'm Vassiliki Fotaki, the Medical and Scientific Project Manager at Digestive Cancers Europe. Today I will present you our research strategy, and I hope that by the end of my talk, I will convince you that we can achieve a lot more working collaboratively and putting the patient's journey at the center of our work. There is a need for continued research in digestive cancers. Digestive cancers are under-investigated and under-funded in Europe in relation to their high burden of disease. Of course, there are limited resources, which create a high demand for prioritizing research activity and funding. However, research should expand and encompass the so far limited studies on the effectiveness of healthcare systems, as described previously by Stefan. This is a scatter plot of different types of cancer and research outputs in relation to their burden of disease measured by DALYs, Disability Adjusted Life Years. The red dots correspond to outputs in 2002, while the green dots correspond to outputs in 2013. In general, for most digestive cancer, there has been an increase. Here you have the esophageal, pancreatic, the colorectal. However, in the case of gastric cancer, the research outputs have been decreased. But the important thing from this scatter plot is that for all these digestive cancers, the research outputs in relation to the burden of disease are lower than in most other types of cancer, with the exception of lung cancer. Digestive Cancers Europe supports and promotes topics with the patient's journey in mind. These topics include research in primary prevention, in secondary prevention, research in delays in the diagnosis, the availability and quality of diagnostic tools, research on available treatments and access to innovative drugs and personalized medicine, but also research in other sectors less studied, such as the psychosocial, holistic healthcare, and occupational health support. Research on views and current state of patient decision-making tools, the support that is available for carriers, the quality of life of patients, the palliative care across Europe, research on the awareness, fears, and misconceptions around digestive cancers, the cultural differences in concepts related to diagnosis, screening, and support, and the role and impact of local support patient organizations in the patient's journey. Our research vision is that patient insights lead to better research outcomes. Some of our priorities in digestive cancer research include the identification of gaps and best practices in the patient journey, to act as the bridge between patients and all relevant research, to influence the research agenda at European level based on patients' needs, to focus and support and promote patient-centric research, to lead research prioritization discussions, ensuring that scarce public funding is allocated to the most needed research topics, to raise public awareness on the need of digestive cancer research, to support and facilitate collaborative research among European nations, to translate research findings into policy, to communicate and disseminate research outcomes to the European patient community, and also to publish research findings in scientific journals. Our value statement includes first-hand insights into patient needs to identify healthcare and translational research and societal gaps, and also a collaborative spirit towards better health outcomes, being the patient's well-being the center of our efforts. So why should you work with us? What is that we can offer? We offer an unbiased, non-commercial, fully patient-centric approach. We offer insights from a diverse patient population from the European Union and the World Health Organization European region. We have guidance from our expert medical advisory committee and our patients and carriers network. We have a high-level European network with research centers, the cancer community, EU politicians, and policy experts from political and institutional worlds. We have strong links with patient experts and advocates from many of our local organizations. And we have proven success in patient engagement and communication. We offer institutional insights as we are fully informed and registered at European level for research participation. We are trusted partners for projects that require direct patient engagement. We offer insights into every step of the research process, ensuring that the patient perspective is fully integrated. In addition, we have scientific expertise and experience in research fund acquisition. Our staff have experience in research project participation and management, and we are multilingual, having the capacity to communicate with different local organizations across Europe. There are different ways we can work together. We can invite you to join us in projects we have already put forward, or we can partner with you on already initiated projects or activities. We work collaboratively. We support full engagement in a project from conception or from the earliest stages possible. We advocate and promote the successful outcomes of research collaborative projects. We support open communication and dissemination of research findings to the general public and the scientific community. Our research partners include academic institutions, research centers and hospitals, national patient organizations, industry, and European patient organizations. Some of our research examples include a project funded by Cancer Research UK on single-cell cancer evolution in the clinic, a project funded by an EU Horizon 2020 grant, the ultrasensitive plasmonic devices for early cancer diagnosis, surveys on the unmet needs of patients living with metastatic colorectal cancer or gastric esophageal cancer. Zorana Maravic is going to talk to you about these two projects next. We also work with other European patient organizations to prioritize the research agenda based on patient needs. And we offer insights into clinical trial design, protocols, and other materials for patients which are produced by pharma. Our principal aim is to participate in research initiatives that will bring short or long-term benefits to patients' lives. And I invite you to join us to this aim, because it's something that brings better outcomes. For any questions, please feel free to contact us.
Welcome to our Satellite Symposium, Leading Change for Improved Patient Outcomes. My name is Jola Gore-Booth, and I was the founder of Europicolon and now co-founder of Digestive Cancers Europe and also an executive director. Digestive Cancers Europe has grown out of Europicolon, and my presentation is going to be on screening. What now? I have spent over 15 years working in the area of colorectal cancer, and I'm disappointed to see how slowly colorectal cancer screening across Europe has developed. We all know that screening saves lives. In Europe, around 500,000 people are diagnosed every year with colorectal cancer, and sadly, nearly half die. And yet, with early diagnosis at, say, stage 1, people would have a 90% chance of survival in comparison to a stage 4, which is 8%. And if we address the finances as well, from 4,000 euros to 40,000 euros expenditure. So a best practice national screening program could halve the number of deaths annually and dramatically reduce costs. The problem we have is that across Europe, formal population screening programs have taken a long time to actually begin. You will see the grey areas of this map is still all the countries that do not have formal population screening programs. And in those where there is screening programs, or there are screening programs, we see that the participation rates are not exactly impressive, other than in a very few countries, Slovenia, Lithuania, Denmark, the Netherlands, and the Basque country, where we know that participation rates are meeting their targets. The other problem we have is that we don't have enough participation data. We don't really know accurately how many people are or are not taking part in these programs. This chart, courtesy of the Integral Cancer Center in the Netherlands, shows that thanks to their best practice and an excellent screening program, they have managed to reduce the incidence of colorectal cancer. This is a map that we should be seeing across the whole of Europe and not in just 1 or 2 countries. So the past, where we stopped at a point where there was still a lot of work to be done, and then came a pandemic that has knocked us off our feet and claimed far too many lives. if you look at this chart, you will see that at time of going to press, the WHO showed figures that 2.5 million people were diagnosed across Europe with coronavirus, and relatively low, nearly 134,000 people died. Every single life was precious, and it is very, very sad that we have these losses. However, if you look at colorectal cancer, nearly 500,000 people are diagnosed with colorectal cancer, and as I have just said, 265,000 die. That is not acceptable, because that is half, as I keep on reiterating. When the pandemic started, countries started to make adjustments, and thanks to Professor Halloran, who helped with this slide as he did a study with other colleagues around the world as to what the situation was with colorectal cancer screening. You will see some did a short period of stopping and have restarted. Others are still under review, and it appears that the only country that carried on throughout and continue to do so now is Denmark. We then looked in a little bit more depth as to what actually their ambitions were after COVID in terms of coming back to what will be the new normality. I won't go through all of these, but I picked out a few. In Poland, local centers are being given autonomy for opportunistic screening. In Denmark, even though they've been going strong the whole time, they've reduced their tests by 30%. In the Basque region, they are expecting to delay 50% of normal invitations. And in Germany, the focus is solely on symptomatic patients, but all of them report a huge backlog. So the coronavirus has created many challenges for detecting and treating colorectal cancer. A significant backlog, which we've already talked about, of non-urgent cases. Reticence by citizens to visit hospital because they're scared that they might put themselves at risk. Late presentation will mean a higher risk operation, and obviously a greater cost to an already overburdened health system. So we started to think about potential solutions for clearing the backlog, and here are some that we thought might be helpful. Screening only symptomatic patients until services are more stable, screening only high-risk target groups, possibly by increasing the threshold for FIT, improving communications with the general public by all stakeholders, including patient organizations, to allay the fears of going to hospital. And I'm sure that that would be improved if we were able to demonstrate that we had enough PPE in hospitals, and thus gaining public trust. Extra monitoring on participation to prevent no-shows for colonoscopy. And I strongly believe that emergency funding should be made available. But we have to learn from this, lessons for the future, so that if we get another spike, we're not going to be caught unawares. It's important that we start working towards getting more accurate records of participation rates. These will help us develop more effective screening programs. The EU has to update its screening guidance, and this guidance needs to be adopted right across Europe. Too many countries keep on saying, for all kinds of various reasons, that they cannot start screening. Wider implementation of best practices from countries with successful screening outcomes will reduce the death rate and healthcare costs, and we have that evidence, which I showed earlier. Funding must be made available to prepare for any future incidents, as I mentioned, another pandemic spike. So what are we as Digestive Cancers Europe doing to help make the situation better? On the 30th of November, we're holding a screening summit, and it will be inviting all interested parties in colorectal cancer screening, national and regional screening agencies, cancer registries, national ministries of health, policymakers, industry, We invite you all to join in to an open discussion to improve the screening practices in Europe. We'll also be presenting our joint statement on colorectal cancer screening. But more importantly, what is the ambition of this meeting? For more years than I can care to say, I have been hoping that we could have a European colorectal cancer screening platform, somewhere where we can get together, work together, and make a difference in the figures that we saw at the beginning, that half of those diagnosed will die from colorectal cancer. So thank you for listening to my short presentation. If anybody would like more information, you have my email address at the bottom of this page. I wish you well, keep safe, and I hope to meet with you soon. Thank you.
I have the pleasure to give the last presentation of the symposium, and I hope that you will keep watching it until the end. My name is Zorana Maravic, and I work for Digestive Cancers Europe as Director of Operations. I will start by reiterating some of the key points on Digestive Cancers Europe. We are the European umbrella organization of a large group of national members representing patients with all types of digestive cancers. Our mission is to contribute to early diagnosis and decrease mortality from digestive cancers, and to increase overall survival and quality of life. In order to do so, we need to understand what are the needs of this patient population. For the purpose of understanding patient needs, we need to know patient journey. This is a simplified scheme of a patient journey. When I was producing this slide, I had in mind a metastatic colorectal cancer patient. Obviously, this journey is different for different cancer types in different stages of the disease. Another thing that makes a difference is where the patient is being treated. But I do not wish to go into all these details, but what I want to demonstrate with this slide is that from the moment our patient experiences symptoms until the very end of this journey, whatever that is, there are many questions our patient has, many needs to be addressed. Beside the patient, we should not forget those that care for him or her, partners, family members, friends, and others. And they all have their questions and needs. The whole healthcare team plays an important role in addressing many of those questions and needs, but there are needs that are not addressed by the healthcare team. And this is where patient organizations play an important role. In order to answer the questions and needs to be addressed, patient organizations have developed different patient support programs. This could be a telephone helplines, peer-to-peer support, which is when patients that underwent similar experience and additional training on how to support others support newly diagnosed patients. Various online forums and tools, psychological support, information sessions, nutritional advices, and other types of support. We also learn from these services and the information that we gather from working with patients we use to improve patient support programs, to help improve hospital practices or develop best practices, to guide policies, drive research, or support health economic decisions. In the first presentation of the symposium, you have heard on the importance of data, and that reality there is a lot of data that unfortunately we do not have. For us, data collection is important to strengthen our credibility. We cannot simply put certain information on the PowerPoint or a policy document and expect that this proves our point. We have to collect the data to understand what are the needs in order to be able to solve them. I will give some of the examples from data collections that we did. We did patient surveys, like the survey on the unmet needs of patients living with metastatic colorectal cancer, and currently we are running the survey on the unmet needs of patients living with gastric or esophageal cancer. We also organized focus groups where we gathered patients and carers to discuss some of the topics. Last year, we organized the focus group to understand the needs of those caring for somebody living with colorectal cancer. And in 2018, we did the focus group to understand patients' views on biosimilar medicines. The question is how we use the data afterwards. Well, to produce scientific abstracts, last year we had 2 abstracts at this conference, and I hope that next year we will have again. Then to produce manuscripts, reports, guides, position statements, or other papers and policy documents. In continuation, I will give 4 examples. The survey on the unmet needs of patients living with metastatic colorectal cancer was a survey available both online as a paper version in 11 languages. This 18-page document was developed by us, working together with patients and carers, reviewed by clinicians and experts in outcomes research. The recruitment period was 18 months, during which we managed to recruit 883 patients. These graphs showed the number of patients recruited per country. The majority of patients came from Serbia, Poland, Spain, and Hungary, with majority of questionnaires completed in paper format. The first section of the survey covered demographic details, which was followed with questions on their disease, more specifically on discovery, diagnosis, treatment, and support, while the last section had 2 ERTC questionnaires, the QLQ-C30 and CR29. Among those patients that completed the survey, the completion rate was pretty high. We managed to publish 10 abstracts, and currently we are in the process of 2 manuscript submission. I have listed some of the survey findings that might be of interest. Among the surveyed population, very small number of patients was diagnosed via screening programs. Only 11% of those that were in the screening age, while almost 20% of the total number were diagnosed through an emergency hospitalization. Of those in the screening age, 45% had not been invited to participate in screening programs, but would have gone if invited, while 7% had been invited but declined to participate. For us, this was not very surprising because we know, and you have seen this in the previous presentation, that screening is done properly in few countries only. When it comes to the process of getting the diagnosis, more than 70% of patients were diagnosed within a month, but unfortunately, a quarter of all patients were misdiagnosed at the beginning. 58% of patients started with the treatment within a month, 29% waited up to 3 months, while 12% waited even more than that. When asked how they felt about the whole process, overall, 1/3 of patients were not satisfied. When it comes to treatment and treatment decisions, 17% of patients felt their views had not been considered in the decision-making process. 22% of patients said they had been tested for RAS mutation, while 74% of patients believed they had been given clear information about the treatment side effects. Not surprisingly, for a majority of patients, their oncologist was their most valuable source for medical information, but 36% of patients felt they should have been spoken in a language they understood to improve their relationship with the healthcare team. So please keep this in mind next time you see a patient. 26% of patients believed psychologists should have been there to help them. And when asked about encountered difficulties, almost half of patients encounter some kind of difficulties after colorectal cancer diagnosis, such as losing their job, having to take time off from work, and overall, metastatic colorectal cancer negatively impacted their income. The survey that is still recruiting patients is the survey on the unmet needs of patients living with gastric or esophageal cancer. The survey is available on our website in 14 languages. It covers discovery, diagnosis, treatment, care, and support for this patient population, as well as the health literacy and demographics. Currently, around 400 patients have completed the survey, mainly from Italy, Poland, Spain, UK, and Latvia. Recruitment is to be finished in the next couple of months, and I have to say that you, the clinicians, play an important role in patient recruitment. The next project is the Carers Guide, which is a booklet developed from the insights we gathered from a focus group that was organized in 2019. We have recognized there are many challenging moments that caring for someone with colorectal cancer can bring, and that carers are often neglected. Our guide covers medical, psychological, emotional, social, practical, and financial aspects of caring for somebody living with colorectal cancer. This booklet is available also on our website, currently in English, but it's being translated, and we hope in future to develop this guide further. The last project that I will mention is the position paper on the usage of biosimilars in colorectal cancer. On one hand, we know there are inequalities in access to biological medicines, which make biosimilars an appealing option. On the other hand, the question was what patients know on biosimilars and how do they feel about them. We organized a workshop with our patient and carers group, during which we discussed all the issues around biosimilars, and we came to the conclusion that biosimilars are safe and effective option. We also believe that patients should be front and center of the decision-making process around biosimilars, but not just around biosimilars, but throughout the whole patient journey. This means having access to comprehensive and clear information about biosimilars and the original biological medicines, and crucially, patients should never be put under pressure to choose or switch for cost reasons only. The position paper is available also on the website of Digestive Cancers Europe. At the end, I hope that I have demonstrated that patient organizations can and should generate data, that we play an important role in patient support, and that by working together, we can improve patient journey. With this, I want to thank you for staying until the end of the symposium. I hope you found it to be interesting. And in case you want to reach out to me or any of my colleagues, please send us an email. To find more information on some of the topics that we have discussed during the symposium, please visit our website. I hope to see you all next year in Barcelona. Thank you.